Okay, thank you for that kind introduction. So in the first 15 minutes, we'll talk a little bit about some of the imaging components of transcatheter mitral valve implantation. So I always like to frame these sorts of talks around cases because it sort of brings us back to our patients and what we're doing every day. So in this case, I'll show a mitral valve and valve where we also did a lampoon. Just to show some of the imaging principles that really apply to all of our transcatheter mitral valve replacements, whether it's a valve and valve or potentially in a native valve. And then in this, we'll look at the screening imaging that we do for TMVRs, and then we'll also look at a little bit about intraprocedural imaging, keeping in mind that, every specific procedure and specific device has its own protocol, but a lot of the principles still apply. So our case is pretty extreme, as you'll see. It's a 44-year-old woman. She actually was admitted after a period of being lost to follow-up in respiratory distress and cardiogenic shock with a bad renal injury as well. And she basically had a bioprosthetic valve that had been placed several years prior. This was out of state, so we don't know the conversation behind why she had a bioprosthetic at such a young age. It was for rheumatic valve disease. She basically presented in this extreme situation because she had severe bioprosthetic stenosis with some regurgitation, very severe pulmonary hypertension, underfilled LV, very bad RV dilation and dysfunction, and then she has some other comorbidities. And then this is relevant because, as you'll see, we took a transcatheter route because our surgeons essentially found that she was really non-operable in her current state because of extreme risk. And so you see these are the baseline TT images. So we can already get a sense that that LV is extremely underfilled and squished down, and the RV is very dilated. And then what's concerning on the left on the peristernal long, when we're thinking about transcatheter mitral, the first thing that comes to mind, of course, for us is the LVOT and obstruction. And while we hope that the LV would fill after improvement of the valve, we have no guarantees that that's going to happen or the time frame where we can expect that to happen. So she did end up having a baseline TE, of course, just so we could understand what was happening. So similar to the TT images, we will, use the same type of imaging protocol that we do for any mitral assessment. So I usually like to start with the intercommissural view of the mitral, and I try to map it from end to end using the biplane. So here we're sort of cutting in the middle of the valve, trying to look at, obviously the leaflets are extremely degenerated. They're very thickened, extremely restricted as well. And then again, we get the impression on the right side of the screen where we're seeing the LVOT there that the space is really very small. If you look at the centimeter markers on the side of the screen, probably like a centimeter at most in an underfilled state, but again, no guarantees in terms of what will happen. One of the things that we can do using 3D echo is we can try to also look at what's the LVOT area. We can't do the same type of prediction as I'll show shortly with CT for neo-LVOT, but we can, play with the reconstruction a little bit to get a sense of what the actual shape of the LVOT, which I've highlighted here in yellow, using the MPR reconstructions. These are the 3D images. So again, the atrial view, you can see the extreme bioprosthetic valve dysfunction. Really, the leaflets barely move. There's still some central regurg because the leaflets are so stiff. And then I really like to look at these valves from the LVOT view from underneath as well, because I think it gives a lot of extra information. So in this particular case, because we were thinking about using a lampoon procedure to reduce the risk of LVOT obstruction, I always look at the post configuration relative to the LVOT. Of course, it's a lot better when it's like this and you have two posts facing the LVOT and a leaflet in the middle, as opposed to a single post right in the middle of the LVOT. So when we looked at this, our conclusion was that clearly the valve is diseased, but also the post configuration would potentially be favorable for lampoon. Fix the audio there. I also look at the fossa in 3D on the echo to do some analysis. Again, we do this routinely on CT, but I like to always get a sense on the mitrals as well. And so we often will look on 2D, and if you think about, for example, mitral clip imaging, we're always taught to look at the height in the forechamber. I find that 3D is very helpful too. So you can do an on-fast view looking directly at the fossa from the left atrium. It gives you a sense of both height and the anterior-posterior position. And then if we actually do a crop plane through the fossa, we can get probably a more accurate estimation of height, just because we are not dealing with an abnormal imaging plane that's cutting diagonally, for example, towards the valve. Because she had the severe renal injury, we were only able to do a non-contrast CT for her, and usually for these valve-in-valve procedures, what we're trying to confirm, of course, is the bioprosthetic internal diameter and area and perimeter-derived diameter, but really they're relatively circular, so they should be pretty similar. And in this case, it was 26 millimeters. In the perfect world, when we're analyzing people for a valve-in-valve, we usually actually want to do, of course, a contrast CT and ideally ECG-gated for all phases. And the reason for that is because we do a few things. So in addition to doing the valve ID measurement, we also usually will do a virtual valve implantation. So you see that on the right of the screen. And in this case, because we know we'll be using a sapien, we approximate the shape and size of it as a cylinder. And we match a cylinder, of course, to the valve frame size. And then once we put that in and we define the center line of the neo-LVOT or the new LVOT that results afterwards, we're able to find the narrowest part and try to measure the area. The same thing can apply to really native valves. So if you're putting in a transcatheter mitral valve replacement, which are worldwide all investigational right now, but for example here we have an STL that's specific for a high life valve. And so in this situation, again, we can look to see how does that specific valve shape fit, and then what happens with the neo-LVOT size in that point of view. And then, of course, the annular measurements, similar to the other valves, we can also do with these native valves. Specifically for TMVRs, we care a lot about LVOT obstruction, of course. It's one of the common and feared complications. So if we look in the literature and we think about the potential predictors, that neo-LVOT area I showed you, I put a range there because different studies have different cutoffs for higher risk. In general, if it's over 2 centimeters, we think of it as being quite large and probably not high risk. And then if it's less than 1.7, for sure, that's quite small. Yesterday, you also heard a little bit about this aortomitral angle, and essentially the shallower this angle is, the higher the risk of LVOT obstruction. And then there are other anatomic factors like septal bulge and the length of the anterior leaflet, more applicable, of course, in the situation of a native valve that you're trying to replace inside of. As I mentioned, I look at the septum on the 3D echo, but commonly we do access planning on the CT as well. So we'll look at the fossa distance from the valves, and then we can also predict the actual approach angle depending on where you've punctured the fossa. And this is very device specific, but different companies or different devices, depending on what you're using, you can try to predict what the ideal puncture position would be. So going back to our case, so for multiple reasons we thought that she was at increased risk for LVOT obstruction. Also because she was young, this was an extreme situation. We really recognized that there was no reserve for failure. So we didn't want to recognize after the fact that we were running into LVOT problems. So our procedural plan was to proceed with a tip-to-base lampoon, and then a valve-in-valve, and then with the lampoons and actually in general valve-in-valve at our center, we use sentinel cerebral protection for all of them just to reduce the risk of embolization from the actual degenerated valve tissue. So then just moving forward towards the intraprocedural imaging side of things. So as you've heard multiple times in the talks, a good transeptal puncture is really key for a lot of these mitral procedures. And so we like to do ours in biplane imaging. So we set up a bicaval view on the left, and we can watch the catheter drop into the fossa. And then on the right, initially we start with a short axis view, and that gives us, of course, our anterior-posterior position. And then in a very sort of quick, efficient way, we can actually already optimize our position. And then just by changing the secondary angle, we flip immediately into a 4-chamber and can do our height measurements. And then in this situation, once we do the initial puncture, I also will recheck again in 3D. And again, the two views that I use are the on-fast and then crop through the fossa where it's crossed through. Again, just to make sure that the position seems to be appropriate and the height is what we expect. Not relevant to, of course, the MVR specifically, but for example, with mitral clipper edge-to-edge, this is extremely useful just to understand how anterior and posterior you are as well. Because her valve was so stenosed, we also try to provide as much imaging guidance, of course, for every step of the procedure. So here we're trying to cross with a 5 French pigtail through a Nagari catheter, and we give some 3D guidance so we have some idea where that central small orifice is. And then in this case, we did pre-dilatation. And then again, the imaging modality that's being used for every step is really dependent on what we're looking for. So in this situation, we're of course monitoring what's happening with the degree of MR. And then so the 3D imaging here, not as important. So we're using color compare here. So we can monitor the position of the balloon on the left and then what's happening with the color flow on the right. When we actually set up for our lampoon, so I think we're going to hear more about that at a later talk. Basically, it's an electrosurgery technique that we do from a transcatheter point of view. We use a lot of 3D image guidance for this as well, because basically our cutting wire, we want to make sure it's positioned appropriately on that anterior leaflet that's facing the LVOT, ideally towards the middle. So that's that image on the left where we're trying to optimize our position. Once we're cutting, there's lots of bubbles, so you can't really see the actual cut itself. And then on the right is the post part of the lampoon where you see that there's that slit that's being created in that anterior leaflet. And again, in this situation, I like to look from both the atrial side and the ventricular side because it can really show where exactly that position is of that cut, especially relative to the LVOT. We, of course, then check with color Doppler at all of the steps that we are going to potentially be modifying leaflets. And no surprise here, we've created a really large amount of MR. And then we're really able to move into the next position, which is the valve-in-valve component. So depending on the type of device that's being used, there's oftentimes a combination of biplane imaging or potentially 3D imaging. I'll show examples of both here. It really depends on the device itself. For valve-in-valves, because you're constrained by the surgical valve that's pre-existing, most of the time the valve will essentially kind of self-center, even if it's a little bit canted initially. So biplane imaging is usually quite adequate. But in situations, for example, if you're replacing in a native valve, that initial alignment and trajectory may be very critical. And then in those situations, NPR will give you that flexibility to really align those planes. The trade-off, of course, being that you lose spatial and temporal resolution whenever you're working in a live 3D mode. So after we basically had the initial setup in biplane, we switched over actually to NPR in this situation. So you see what that NPR looks like. Yesterday in the talk that I gave for tricuspid, I showed similar setup planes that we do for the tricuspid. The mitral is very similar, so we try to generate an en-face view, and then we'll generate cut planes that are usually corresponding with the intercommissural view and the long axis view through the LVOT. And then using 3D, and you can see here, using the newer probe, so the X8 with Philips, we can get very good volume rates, even though we're using live 3D, and the probe actually doesn't overheat even when you're using this for quite a period of time. In this particular case, we're also using this in our lab where we had fusion imaging. There's always lots of debate about how useful fusion imaging is for a lot of these procedures. Oftentimes for paravalvular leak closure and these valve replacements, I find it can be helpful. It just gives us a little bit of an extra, dimension and appreciation, especially in the fluoroscopy. So here you see that we have our 2D with color that's overlaid on top of the fluoroscopy, and you can appreciate that very small amount of paravalvular regurgitation near the left atrial appendage. And then you can also see that we were able to put markers using the fusion imaging, so in this case the septal puncture position, and then we usually also mark the left upper pulmonary vein because our guide wires may be going up there and we want to avoid, of course, the appendage. Just looking at our case again, so post-implant, again, for this type of device or other types of transcatheter devices, lots of 3D evaluation, especially in the post-implant, is very important. So in this situation, both to confirm that we have good placement and sealing from the point of view of using color Doppler. Looking at paravalvular leaks in particular, on 2D imaging planes, you can see them very well, but you have to do a lot of sweeping, either just by rotating the probe or by changing the angle or using biplane sweeps. Otherwise, the abnormal positions of these leaks can sometimes be missed in standard imaging planes. So 3D, we find, is a really good way of just getting a good overview of what's happening, and then we can refine with 2D. And then again, the LVOT view I find particularly helpful, especially if we've done something like a lampoon. So here where I've marked with the red arrow is that anterior part of that valve facing the LVOT, and we can see that there's actually color flow that goes through what we would expect normally to be sort of a solid part of that cylinder. So we can at least confirm and feel good about ourselves that we've actually done something there. When we're looking at the LVOT after TMVR, so usually the gradients we really need to assess in a deep transgastric window. You can also do transthoracic, of course, but that's cumbersome in the from the point of view of just positioning in the sterile field. So when you go deep transgastric, either at 0 degrees or 120, you're usually very well aligned. And so in this situation, we see here that there's really no significant LVOT obstruction that occurred, which was quite a relief. And then again, we just checked with MPRs again in 3D with and without color, just to, again, get a good idea of what's actually happening with the flow and also what the final valve shape looks like in this case. And then this patient actually came back for an infection at a later date and had a TE. This was to rule out endocarditis. But again, the nice thing about this study is we're able to confirm again that we still have that anterior opening from that slit and still no LVOT obstruction that you can appreciate on these aortic valve views. So in summary, through this case, hopefully we've been able to discuss a little bit about some of the imaging around TMVRs, in particular the screening. So ideally, really a good TE and a contrast CT, and then some of the aspects of intraprocedural imaging as well. Thank you.